So my topic is age-related infertility, decline, and age-related infertility. Why should we wait while we can start treatment very early? So the objectives are definition. We'll talk about cutoffs, 35, 37, or 40, the cellular and molecular mechanisms behind aging, and the 6-month issue that we should investigate the old women after 6 months only, not after a year. The management is multidisciplinary management. It includes diagnosis, prophylaxis, to maximize the stimulation protocol, to maximize the laboratory KPIs, maximize embryo selection. So it's not just the IVF cycle. There are things before the IVF cycle and things during and after that. The thorny business of embryo accumulation and PGTA will be discussed by myself and Professor Hisham Saleh, because in those particular poor patients, we need a lot of embryos to have one normal eublast, and PGTA is very expensive, so we need to discuss this a little bit. Aneuploidy is not a stigma. It's not that it has to be there. Aneuploidy is a dynamic process related to spindle and checkpoints, related to telomeres. All these things can be manipulated, possibly, to decrease the incidence of aneuploidy. So fertility is the capacity to establish a clinical pregnancy. Age-related infertility, the fertility decline is a biological phenomenon. It's not a disease. It's just a decrease of the primordial follicles that are present in the ovary, demarcated by low AMH, lowering AMH, higher FSH, etc. But it's not a disease, because those women can get pregnant. Age-related infertility is the disease, and age-related infertility is a proportion of women who have age-related decline of fertility. This is the first distinction that we need to make. So it's not only quantity, it's also quality, because aneuploidy reduces the quality of embryos, and it is associated with high miscarriage. The choice of the cutoff age of 35 is related to an increased aneuploidy rate in this age. And specifically, the chromosomal abnormalities are related to this age. If you can look here, these are the results of ICSI after one completed cycle. These data are from Australia, 11% in women 40 to 44 years. And from UK, 3 completed cycles, the results are 10% in women over 40. Yes, spontaneous pregnancy is 5% per month in women over 40, but over a year, the pregnancy rate is really acceptable. It can reach 30%, as you can see here. So there is a good chance of spontaneous pregnancy as compared to ICSI or IOI. The results of IOI are half that of ICSI, despite 3 repeated cycles. The high aneuploid rates in women over 40 is related to dysfunctional cohesions or cohesions, dysfunctional spindle assembly, or the checkpoints are not working properly, shortening of telomeres, and mainly impaired mitochondrial function, which can affect the 3 aforementioned factors. It can affect cohesion, affect spindle assembly, and mitochondria can affect telomeres. All these processes are directly or indirectly are involved in propagation of the sperm along the spindle. Diseased mitochondria is associated with a lot of problems, and zygote and embryo mitochondria are inherited from the mother. So after fertilization, the sperm mitochondria is ubiquinated and it is removed. So you are left with what you inherit, the embryo inherited from the mother, and it decreases in cells repeatedly. And accumulation of mitochondria that is diseased is moved by a process called mitophagy. If mitophagy is dysfunctional, diseased mitochondria will accumulate and it will lead to cell death. And mitophagy can be improved by a lot of things that we can do. So again, The treatment is multidisciplinary. The first item of them is diagnosis. The most important in diagnosis, of course, is age. And we have to discuss which cutoff we need to talk about, 35, 37, before 35 or 40 or after. Now, the big problem of MH. MH only predicts quantity. It does not predict quality. It does not predict pregnancy. It does not predict menopause. We cannot use AMH to stigmatize those poor women and say, yes, you have low MH, then you have to go to ICSI. So MH is not only a marker of ovarian aging. No, AMH by itself, it acts on primordial follicles, it acts on oocytes, and it is an anti-apoptotic. So AMH by itself is beneficial. Why you are saying this? Because there are a lot of things that can be done, either to improve MH or to improve mitophagy or to decrease aging, and they include telomerase activators, epigenetic regulators, antioxidants, traditional Chinese medicine, caloric restrictions, immunomodulators, hormones. And at this point, it is very important that we answer a simple question. Desperate situations require desperate measures or not? Should we just say, no, wait for evidence, while women who have 40 years of age are having a poor copy of IVF because it is not effective, or we can use methods that are not expensive nor even invasive. Prophylaxis is oocyte freezing. We need to discuss the age limit of oocyte freezing, the ovarian reserve limit, and of course we have eminent laboratory personnel that directors that can tell us about how to improve the outcome of oocyte freezing. The clinical, the name of the game is to exploit the ovary. Just do the best to take all the oocytes from the ovary, because you need, for example, 15 oocytes to have one normal eoblast in those poor patients. So we have to be careful about increasing the dose or increasing the cycle. Due stem and embryo accumulation are the name of the game for Poseidon 4 patients. It's not increasing the dose. And this has to be discussed also. Coenzyme Q10, DHEA, and vitamin D are adjuvants that can be used. They are inexpensive, they are not invasive, and there is some evidence for those poor patients. For example, coenzyme Q10 acts on the electron transport between 3 of the complexes of the mitochondria. And there is some evidence for meta-analysis that shows that coenzyme Q10 can act in ovarian aging. Most importantly, there is data showing that coenzyme Q10 in the dish can improve the outcome in poor patients. So maybe we are using coenzyme Q10 in the wrong way. We should use it after HCG because it's working on the dish. So this is something that can also need to discuss. Vitamin D, I came across a very nice evidence that vitamin D has a responsive element on the anti-Mullerian hormone, which we said before, it is useful for the follicle function and for the oocyte function. So vitamin D can act on the promoter of the MH gene to improve AMH. And there is some evidence that AMH is related, vitamin D is related to MH. So why not? Why not? It's not expensive and it is not invasive. Of course, PRP is invasive, so this is something that has to be discussed separately. There is a lot of talk about spermidine, about a lot of factors that can improve oocytes. And lastly, the PGTA, we have evidence that PGTA is favorable in patients with advanced maternal age. And there is 2 meta-analyses, 21 and 22, and there are a lot of evidence which Professor Hisham will allude to. And thank you very much, Andy.